Hey everybody, it's Dr. Gilchrist and welcome to week 2 of Drugs and Behavior. So by the end of this week, we will be 1/3 of the way through the course. And I think you're going to like this week a lot, largely because we are going to begin to talk about some of the different types of drugs this week. So this week we're talking about some of the different properties of drugs, including both pharmacokinetic properties and pharmacodynamic properties. We will be talking about our understanding of drug abuse and addiction and why it occurs. And then we'll finish up talking about our very first drug. We're going to start by talking about alcohol and its different effects. But we're going to go ahead and start today by talking about some of the different properties of drugs. So here is the overview for you. So we're going to start by talking about pharmacokinetics and pharmacodynamics. And just as a reminder from last week, pharmacokinetics are all about how the drugs move throughout the body, how they are distributed throughout the body. Pharmacodynamics are actually how these drugs cause biological changes. Then we'll talk about how these psychoactive drugs interact with receptors on different types of neurons, and we'll finish up by talking about how our bodies adapt to chronic use of drugs. So let's start by talking a little bit about pharmacology and drug action. So just as a quick review from last week, and I know we talked about this in our first section, we need to have a discussion of what drug action is versus drug effects. So first of all, one of the things that we know is that when a drug binds to a receptor, whether it is ionotropic or metabotropic, drugs are going to enact molecular changes. And these are what are known as drug action. So what is chemically happening with this drug? And these chemical changes will create changes in both our physiological and our psychological states. And these are the drug effects. Now, one thing that I will mention is that when we talk about drug action versus drug effects, the site of drug action and the site of drug effects may not always be the same. So here's kind of a very simple example. So there's atropine. Now, atropine, if applied to the eyes, so we're going to deliver atropine to the eye in the form of an eye drop, that is going to cause your pupils to dilate. So you will often see atropine or drugs that are very similar to atropine at an ophthalmologist's office where you might have your pupils dilated. Now, in this case, this is delivered through an eye drop. The site of action is going to be near the site of the effect. Both of these things are occurring at the site of the eye. Now, let's take an example of things like morphine or different types of opioids. Now, morphine is largely going to be used for pain-relieving purposes, and it's a suppressant. In particular, one of the things we'll talk about in week 3 when we talk about opioids is that opioids make good cough suppressants, and that's because they suppress the respiratory system and allow those airways to open up. But one of the things that we know about opioids is that one potential effect is restricted pupils. Now, this is a case where the site of drug action is going to be very different from the site of one of those effects. So whereas with atropine, the site of drug action is near the site of the drug effect, morphine is basically may be taken orally or intravenously, which is not near the eye, and yet the site of drug effect can be the eye. So sometimes the site of action and the site of effect may not be the same part of the body. Now, one of the things to just remind you, drugs can have multiple types of effects. So generally, drugs can have what are called therapeutic effects. This ideally is why you are taking that particular drug, because it has desired physical or behavioral changes. So drinking something like a cup of coffee that contains caffeine can ultimately provide you with energy. But one of the things that we find is that drugs can create side effects. These are often unwanted or unexpected effects of the drug because of the way the drug behaves. So, for example, caffeine can give you that energy, but it may lead to the undesired effect of increased heart rate to a point where it's uncomfortable. And if you're taking it close to bedtime, it may potentially leave you with insomnia. Additionally, in addition to those therapeutic versus those side effects, we can also talk about a drug's specific effects and its non-specific effects. So specific effects are based on interactions between the drug and the receptor site, and then those non-specific effects are going to be based on individual characteristics of the person, the mood that they were in, previous experience that they've had with the drug. So for example, one of the things that we know about different types of hallucinogens and additionally drugs like cannabis is that your current effects that you are feeling may be based on, for example, with hallucinogens, the mood that you're in. It's better to take them when you're relaxed than when you're agitated. Additionally, we know that for people who use cannabis, prior exposure to cannabis may affect how you behave on it now. And those would be considered those non-specific effects. And this does include placebo effects. Placebo effects are not based on any interaction between a drug and a receptor site. These are based on your belief in the drug actually working. So now that we've talked about that, let's go ahead and talk about drug action, these specific chemical, molecular changes, and some of the different factors that affect it. So what sort of things are going to affect how a drug is processed? And one of the first things that we know is that chemical structure really matters. That will affect potentially where the drug binds and how the drug binds. So to kind of give you an example of how chemical structure can affect different aspects of a drug, we can use an example like heroin versus morphine. Now, something that we're going to talk a little bit about in week 3 is the fact that a lot of our opioids, including opioids like naloxone, which is Narcan, have a very similar structure. In fact, heroin and morphine, both of which are opioids, have a very similar structure. However, the one thing that makes heroin more potent than morphine is the fact that it has 2 additional acetyl groups that are added to its chemical structure. As a result, these 2 acetyl groups make the drug more fat soluble, and that means that it reaches the brain faster and is ultimately going to be more potent than morphine is. So chemical structure can tell us a lot about how potent a drug is going to be, where it can bind, and how it can bind. Dosage is also going to affect this. So in general, the more of a drug that you have in a dose, the bigger the drug action and ultimately the bigger the drug effect. And then additionally, this is a term that's popping up more and more, especially in like TikTok and Instagram wellness spaces, bioavailability. Bioavailability is basically the amount of drug that is actually present in your blood that is ultimately free to bind to different receptors. And so the next question that we have to ask ourselves, because ultimately bioavailability is going to determine how much of that drug is present to bind. So what factors are going to contribute to bioavailability? So here are some of the different pharmacokinetic factors. So we have, first of all, the route of administration which we're going to talk about very soon. So the route of administration is basically the way that you take that drug. Some routes of administration lead to drugs reaching the bloodstream much faster than other types. We also have things like absorption. So this is basically when the drug passes from the site of administration into the bloodstream. Additionally, from absorption, we have distribution. So once the drug reaches the bloodstream, it's going to be distributed to a variety of different organs. And what's really critical is that for this to be able to happen, the drug has to be able to pass into different membranes. Then, after being distributed to target organs and tissues, the drug is going to bind to those receptor sites. And then finally, the drug will be inactivated. At this point, the drug will be broken down into metabolic byproducts or metabolites through enzymes. And then those metabolites or drugs will be excreted or eliminated from the body. So here you can kind of see this process. So we have drug administration, so the pharmacokinetic factors work this way. We have a variety of different routes of administration, which we will talk more about. At this point, the drug is going to be absorbed into the bloodstream and distributed to different types of target tissues. Now, for this to be a psychoactive drug, it is going to have to reach neurons in the central nervous system. So we are going to have some binding to plasma proteins in different parts of the body, but we're also going to have binding to target sites, neurons, so that we can get those psychoactive effects. We will also have binding to storage depots like bone and fat that we'll talk about later. After binding, these drugs will eventually be inactivated by the liver, basically providing enzymes that will break these down into metabolic byproducts, metabolites, and these will be excreted in a variety of different ways through the intestines, the kidneys, the lungs, and the sweat glands. And ultimately, these will create excretion byproducts, including feces, urine, water vapor from our breath, sweat, and saliva. So when we talk about the routes of administration, we're going to make a major distinction between two different types. So most routes of administration are going to be enteral, meaning they're using the gastrointestinal tract, versus paraenteral. So enteral will actually include both the oral method as well as the rectal method. So use of the rectum is part of that GI tract. Paraenteral will include a variety of different routes of administration, including injection of various types and topical administration. So here are some of those different routes of administration here. So here we have the oral tract, which is going to make use of the gastrointestinal system. Rectal will also be included here. We have different types of injection in our paraenteral methods: subcutaneous injection, intramuscular injection. So subcutaneous, we're going underneath the skin. Intramuscular, we're going into a muscle. And then intravenous, we're going directly into a blood vessel. So here you can see the different methods. So different types of injection will go through the rest of the body, will eventually make their way to different sides of the heart, which will then be pumped into the lungs and then distributed throughout the bloodstream. Here we have inhalation, which will also use the lungs as well. So let's talk about each of these administrative methods in a little bit more detail. So we're going to start by talking about oral administration. Oral administration is usually when you are taking a pill form of a drug. It is the most commonly used method. And the reason for this is because it's pretty safe. It takes about 20 to 30 minutes for this drug to actually have an effect, it is self-administered, and it's generally pretty economical. Because we're basing dosage on average body weight, we don't have to worry too much about things like overdosing or getting a very accurate weight to be able to recommend a dosage. Now, here's what's critical about drugs that you take orally. They have to be able to dissolve in the stomach and ultimately transfer to the capillaries outside of the stomach wall. So this is the process of absorption. So once stomach acids have absorbed or have dissolved a good chunk of the drug, that drug has to then transfer to capillaries outside of the stomach. So this is that absorption process. So what this means is that for this to work, the drug has to be resistant to stomach acid and stomach enzymes. So if a drug can't survive stomach acids or enzymes, it's probably not a good idea to take it orally. Now, one of the other things that I will mention that makes oral administration safe compared to other types of methods is that if you overdose on an oral method, there is opportunity and there is time to basically save you from those negative effects, because it takes a while for oral drugs to actually exert their effects. Now, this is going to matter much more for our enteral methods than our para-enteral methods, but there are some different factors that affect how quickly a drug is absorbed. So, for example, we know that the faster the stomach empties, the quicker the drug will work. So one of the things that we know is that food in the stomach can actually slow down absorption, especially if it's a fatty food. Oftentimes you are actually going to see that some drugs are recommended to be taken with food. Some of that could be that it would be uncomfortable to take the drug on an empty stomach. Another reason why you might want to take a drug with food is to slow down that absorption rate so that the drug isn't hitting you all at once. Physical activity will also slow absorption of a drug, and that's because remember that when you're doing physical activity, you are putting physical stress on your body, and the sympathetic nervous system is getting involved. And what typically happens when the sympathetic nervous system is involved? What we're going to find is that digestion is temporarily shut down. And that means that the stomach won't be able to empty as easily at that point. We also know that there is something called the first pass effect. So these chemicals are going to be sent to the liver and altered by different liver enzymes. So this can occur before the drug has even had the opportunity to actually be distributed throughout the body. So drugs are going to enter the liver before they're actually sent to the rest of the body. And as a result, liver enzymes may actually convert drugs to metabolites before the drug ever actually gets into the bloodstream. So here's kind of what that looks like. So here's kind of your first pass metabolism. So here you have a drug that has basically made it past the stomach. It has entered the intestine. And at that point, before it's able to be distributed throughout the body, it is absorbed into the liver through the portal vein. And then some of those byproducts are going to be metabolized. What is left after that first pass metabolism will then spread from the portal vein and basically be distributed throughout the body and thus be bioavailable and will be distributed to other organs and ideally the brain. Now, I want to talk about rectal administration as well. Now, this is a case where you are still using the gastrointestinal tract, but you're actually using a very different method. So the drug is going to be inserted via a suppository that's inserted into the rectum. So what you can see here, so here we actually have the we have our intestines. Here is where we actually have the rectum. And one of the things that you're going to notice is that there are a lot of veins here. And that means that there's opportunity for the drug to actually gain access to the bloodstream without having been dissolved by stomach acid or dealing with that first pass metabolism in the liver. So we're not 100% sure if drugs that are basically given rectally can avoid the first pass metabolism, but we do know that they don't end up being subjected to stomach acid or stomach effects. And this is going to be really good for both babies and for those who can't take a drug orally. So those were the two enteral methods of administration. Now we're going to talk about the parenteral methods. And these methods do not involve the gastrointestinal tract at all. So we have intravenous injection, intramuscular injection, subcutaneous injection, inhalation, topical application, intranasal, and transdermal. Your book also mentions sublingual, which is basically absorbed underneath the tongue. So here are, again, some of those different parenteral methods. Here we have inhalation. Here we have the 3 different types of injection, and you can basically see what happens when each of them enter the bloodstream and the movement of those drugs throughout the body. So we're going to start by talking about intravenous injection. So this is one of the most rapid routes because you are injecting directly into a vein. As a result, it gains direct access to the bloodstream and it reaches the brain near instantly in about 10 seconds or more. And because of that, it's accurate because you are injecting a certain dose. Generally, if you are doing this with the help of a physician, you are not self-administering. Self-administering may become more dangerous if you don't have a guided dose. And one of the other things that you will see is that because it is so quick acting, if you overdose, there is no time to correct this. And as a result, this can be a very dangerous method in addition to being very rapid and very accurate. Now, if you're taking a street drug intravenously, this becomes a bit more complicated. And that's because you may not know exactly what the dose of the drug actually is because of filler material or the way the drug was produced. And there are always going to be issues with the sterility of the needles. Those can be really dangerous. And harmful to your health if you're using unsafe needles that have been injected into veins of other people. And so it's part of the reason why you will often see like needle drop-offs or syringe drop-offs, because if you're going to use, the idea is you should at least use a clean needle because that can cut down on your risk of things like HIV or AIDS or other blood-borne diseases. Now, next we have intramuscular injection. So whereas intravenous has direct access to the bloodstream by injecting into a vein, with intramuscular injection, the drug is injected directly into a muscle. Now, because you're not going right into the bloodstream, intramuscular injections are going to be slower, but they're going to be more even in their absorption rate. So it's going to be more even and it's going to be quicker than oral administration. It's also going to be more even because you don't have to worry about the gastrointestinal tract. It is generally not going to be convenient for patients, and it's not very common for drug abusers. And one of the things that we know is that you can actually slow the absorption rate of this drug further by constricting blood vessels. So that might include taking things like antihistamines or potentially amphetamines. When you slow down when you constrict those blood vessels, as a result, it's going to be harder for that drug to be absorbed from the muscles into the bloodstream. So a couple of different examples of intramuscular injection. This will include things like an EpiPen, and this may also include things like Depo-Provera, which is a contraceptive method. Then we have subcutaneous administration. So whereas intravenous, you're going directly into a vein, intramuscular, you're going directly into a muscle. Subcutaneous is when you are injecting just below the skin, and you're going to get a more uneven absorption rate because of that. Oftentimes, you can do self-administration with this. I believe Ozempic is very much like that. Although it could be intramuscular, I need to look that up and check that out. But here, some very common examples include things like insulin pumps for people that have type 1 diabetes. They get a very slow and steady release of insulin through a subcutaneous administration. And then the contraceptive method, Implanon, where a hormonal contraceptive is basically implanted subcutaneously under the skin. The absorption rate is basically going to depend on how much blood flow that area gets. So for example, you will probably want an insulin pump really close to the gastrointestinal tract. This is an area of the body that is always working. It gets a lot of blood flow, and as a result, we're going to want insulin to be injected much more closely to that region than in a place like the foot. Next, we have inhalation and insufflation. So here, drugs are going to be absorbed into the bloodstream by passing through the lungs. This is very rapid. It has a very high rate of absorption because basically once you have inhaled it into the lungs, remember that your lungs are full of blood vessels. So as a result, it's going to go from the lungs to the heart, then directly to the brain via the carotid artery. This is pretty convenient. This is very common for a lot of different types of drugs of abuse. And one of the things that we do find is that this can potentially lead to damage to the nasal passages as well as the lungs. Then we have topical administration. So this, your book calls this nasal and mucosal membranes. So this is when a drug is applied to mucous membranes. Intranasal administration is going to be a special type of topical administration. This would include things like nasal sprays and snorting. And so that might include things like Flonase, which is presented as a nasal spray. And this can have both local effects, like it decongests your nasal passages, and it can have larger systemic effects as well. This is also going to be very common for drug abusers, and again, it's very convenient for patients. Then we have transdermal, which your book also talks about. This is when a drug is going to be applied via some sort of skin patch. It's going to be more stable than oral administration, but the absorption rate is going to be very variable. It really depends on the pre-programmed rate. It's going to provide an even, sustained release of drug into the bloodstream. So it's very common to hear about things like nicotine patches to basically supplement the body with nicotine when somebody is trying to quit. There are different types of birth control that are also administered through a transdermal patch. Now, one of the things that I'll mention is that the route of administration affects bioavailability. So the route of administration is ultimately going to be related to the rate of absorption. So the more quickly that a drug can be absorbed, the greater the bioavailability is. And it's also going to be affected by that first pass liver metabolism. Drugs that are absorbed and go through that first pass metabolism are generally going to have less bioavailability than para-enteral methods that bypass that. So here you can see kind of a figure of drug concentration in blood, which is bioavailability, and you can see time in hours on your x-axis. So what you can kind of see here is that in general, the intravenous method here in red is going to be the most rapid method. It also has a greater amount of bioavailability than things like subcutaneous injections or oral methods, which here is marked as PO. Intramuscular has a pretty fast rate as well, but if it is embedded in oil, which may happen, this can slow the absorption rate down and lead to a much more steady, stable bioavailability. So now let's talk about factors that affect drug absorption. So once the drug is administered, it is then going to be at some point absorbed into the bloodstream. So ultimately the big question is, which drugs can actually cross membranes? And that's going to be the critical thing here. So the thing that affects whether or not a drug is absorbed effectively is whether or not it can cross a membrane. So it might have to pass through things like mucous membranes or the wall of the intestines. So just as a reminder for you, anytime that you're dealing with cell membranes in any part of the body, they're going to be made up of this phospholipid bilayer. So this bilayer is made up of lipids that have hydrophilic or water-loving heads and hydrophobic tails. And so you have these charged heads that are in contact with aqueous fluid. And based on the nature of this phospholipid bilayer, ultimately what we find is that only molecules that are soluble in fat can pass through. The other thing that we know is that diffusion across these, so they have to already be fat soluble. And the other thing that they need to be is they need to not be ionized. So let's talk a little bit about what that means. So generally what we're going to find is that diffusion works best for non-ionized molecules. Ideally, they're going to have a neutral pH of some kind. So most drugs are either going to be very weak acids with a pH of a little bit greater than 7, or they're going to be a very weak base, which is a pH greater than 7. So acids are less than 7, bases are greater than 7. But generally, they're going to be weak. They're going to be really close to that neutral level pH, which is set at 7. So here's what we know. Weak acids are going to ionize in alkaline solutions, which are bases. Weak bases are going to ionize in acidic solutions. So we want to make sure that drugs don't ionize. We want to make sure that bases are matching up with bases and acids are matching up with acids. So for example, aspirin, which is weakly acidic, is very easily absorbed in the stomach because stomach acids are also going to be acidic. So one of the things that your book kind of mentions to help you out with this, generally drugs with a pKa, or the strength of the acid closer to the local pH, are going to have more non-ionized molecules. So a drug that has a pKa of 3 will have more non-ionized molecules in the stomach, which has a pH of 1, than a drug that has a pKa of 8. So we want to make sure that acids are matching with acids and bases are matching with bases. And ionization is basically producing ions, and that makes it harder for those drugs to actually be absorbed. Now, what other things affect absorption? So we know a couple of different things really matter. In addition to ionization, how often the stomach empties into the intestines will also matter. So basically, the digestive system is going to be really critical here. The stomach has a smaller surface area than the intestines. And generally what we're going to find is that the larger the surface area, the slower the movement is, and the greater the absorption we get. So how often the stomach empties is going to kind of be critical here. So we know that, for example, body weight may potentially affect the rate of absorption, especially if you have more body fat. So generally, the amount of fat tissue that you have lowers the serum concentration of fat-soluble medications, and that's going to affect the effectiveness of the drug. Sex matters as well. So if you are assigned female at birth, you generally are going to have less of a water concentration in your body, and you're going to have more of a fat concentration in your body compared to people who are assigned male at birth. As a result, this will also lead to differential absorption rates between people who are AFAB versus people who are AMAB. So now let's talk about drug distribution. So we've talked about the route of administration. We've talked about absorption. So now the drug has been absorbed into the bloodstream. What happens when the drugs actually reach the bloodstream? So we know that it takes about 1 to 2 minutes for the drug to be distributed throughout the entire body. Generally, areas that have the greatest blood flow are often going to have the greatest drug concentration. So that will include areas like the organs of the gastrointestinal tract. That'll be less likely for things like your feet. And the brain is actually one of those areas that gets a significant amount of blood flow. However, there's one major problem that affects distribution to the brain. And remember, this is a class about how psychoactive drugs affect behavior, which means this drug needs to be able to reach the brain. There's a major problem that we have to talk about, and that is the blood-brain barrier. So what you're looking at here is a cross-section of the capillaries, basic blood vessels in both the regular like the normal part of the body, and then in the brain. And what you're going to kind of see with our normal blood vessels is that here's your blood vessel, but you can see that there are pores that are basically openings for different lipid-soluble substances to pass through. Now, one of the things that you're going to notice is that those gaps are not as present in blood vessels in the brain. So you can actually see where we would expect a pore. We actually have what's called a tight junction to basically create this barrier. And then the gap is basically further supported by astrocytes here. So, other way. So what sort of things create the blood-brain barrier? So as we saw in that previous image, typical capillaries and blood vessels, they have gaps. But in the brain, the capillaries only have what is called tight junctions. Astrocytes are basically going to fill in those spaces, and only molecules that are fat soluble can pass through. Now, another example of a tight barrier that we have is the placenta. So when a fetus is developing, you can actually see here we have arteries and veins in the umbilical cord, and you can kind of see here in the placenta that we have these very tight gaps to basically make sure that harmful substances don't affect the development of this fetus. Now, the difference between the blood-brain barrier and a placental barrier is that the placenta is not actually a complete barrier. One of the things that we know is that fat-soluble drugs can very easily pass through the placenta. And the fetus can actually be damaged through things like acute toxicity or things like teratogens. So acute toxicity may include things like being exposed to the mother's very high drug level. This is going to have a lot of implications, particularly if the mother is a smoker or drinks alcohol, which we will talk about later on this week in fetal alcohol syndrome. Teratogens are basically when developmental abnormalities develop. So, for example, the acne drug Accutane has been well documented to produce birth defects, and as a result, it is very highly recommended that you not be pregnant while you are taking this drug. And if you are a certain age, you might have to take regular pregnancy tests or be on hormonal contraceptives while you take Accutane because of that risk. Exposure to X-rays may be another teratogen. And In addition to binding to neurons and to target tissues, drugs can also bind to what are called inactive sites. These are what are known as drug depots. Now, whereas receptors want to bind to specific types of neurotransmitters and drugs that match those neurotransmitters, those would be what we call selective. Non-selective basically means they will take anybody and they do not care what type of drug it is or whether or not it is a match for this neurotransmitter or that neurotransmitter. So that includes things like plasma protein, muscle, fat, and bone. Drugs can bind to those things as well, and as a result, we get things like depot binding. Now, while the drug is bound to these depot sites, the drug can't reach active sites and it can't be metabolized. So while it's embedded in the body fat or the muscle or the plasma protein or the bone, there's nothing to be done with that drug. However, this can be reversed based on blood level. So if there's too much of a drug in the blood, that drug may bind. If there's not enough places for a drug to bind, it may bind to depot sites, but eventually that will be reversible and it is temporary. So this is sometimes referred to as nonspecific binding. Now, what does this mean? One of the things that we know is that the presence of drug depots means that you're not experiencing the full concentration of the drug you just took. It reduces concentration at active sites. Now, here's what this means. Similar types of drugs are going to compete for depot binding, and these interactions can lead to overdoses. For example, if you are taking Valium and Prozac at the same time, those competitions for depot sites and the temporary nature of depot binding may mean that these drugs will interact and start to cause problems. And additionally, depot binding keeps the drugs longer in your body than you think. So that means that drugs can occasionally be present in traces of your body fat. It can be present in your hair. And that means that this is going to have a lot of implications for things like drug testing. So how are drugs eliminated? So there's two steps to this process. We first have what is called biotransformation, and then we have excretion or elimination. So basically, we're metabolizing the drug and then we're eliminating the byproducts. This process is what is known as drug clearance. This is basically the way that the drug is removed from the blood, and this will affect the size of a drug effect and the duration of a drug's effect. So when we talk about drug clearance, we have to talk about what are called first order kinetics. So the clearance of a drug is exponential. So basically here is the function, and these are what are known as first order kinetics. So what's kind of critical in first order kinetics are what are known as half-lives. So basically a half-life is the time that is required for half of the drug to be removed from the blood. So here you can kind of see the first half-life. The drug amount, which was 0.2, has been dropped to about 0.1 in about 5 or 6 minutes, or 5 or 6 seconds. So you can kind of see after the second half-life, we have gone from 0.1 to 0.5. Third half-life, we've gone from 0.05 to 0.025. And generally what we're going to find is that the length of the half-life is always going to be constant. For most people, it takes between 3 and 4 half-lives for a drug to be completely cleared from the bloodstream. On average, if you took an average of that, the average drug takes about 3.3 half-lives for a drug to be completely cleared from the body. So the half-life is kind of important here because it affects how often you need to take that drug. So if you have a half-life of 8 hours, you're basically going to take that once a day because 3 half-lives is 24 hours. And basically after 24 hours, you have very little of that drug in your bloodstream. If the half-life is less, you're going to take more than once a day. If it's more, you're going to need to make sure that you are taking it as often as directed, because if you take more often, it can lead to toxicity, side effects, and in some cases, developing addiction. Now, half-lives are going to be really important, and I know I just said taken as directed, but research has shown that sometimes even this can be kind of knocked off to the side. So for example, one of the major problems that people have had with OxyContin, which is the trade name for oxycodone, people have gotten, within like the past 20 years, there were a lot of people who were addicted to OxyContin as a pain medication. Now, part of the reason for this is that researchers basically found out that it has a half-life of about 3 hours, which means that the drug is almost completely cleared from your system within 9 hours. But it was often only directed to be taken twice a day. So one of the things that we are going to see, a lot of people who would take it twice a day would end up starting to feel pain before they had to take their next dose. And so what often ended up happening is that people would take a drug earlier than they were told to take as part of their dosage. And when you're taking more than it, that would lead to people taking more than was directed. And what a surprise, OxyContin is very habit forming. It has a very strong physical dependence, and a lot of people ended up getting addicted that way based on poor dosage guidance. After those first order kinetics, which are largely happening through metabolism of the liver, this is when we're going to go through a process called biotransformation. So biotransformation basically leads to those first order kinetics. And this is going to basically, we're going to break these down by enzymes. There are two different forms. There's type 1, which is sometimes called non-synthetic, and there's type 2, which is synthetic. So type 1 or phase 1, you're going to be using a lot of enzymes. Phase 2, you are basically going to be breaking these down further, the metabolites that were produced in that type 1 biotransformation. And one of the things that we're going to find, drugs are going to vary in terms of their metabolic methods. A very common one, some common ones that we're going to hear about are things like CYP1, CYP2, and CYP3 cytochrome P450 enzymes. But it's going to vary based on drug. Now, what sort of things affect liver metabolism? So